Sorry again, I didn't know that I was muted. Can anyone discuss this, please? Eva, can you please make comment?
Yes. So this is a partial photograph showing the cornea. There is conjunctival congestion, and there is a large corneal ulcer along with involving the stroma as well as and with sloughing, and there is a presence of a hypopion also. The anterior chamber details cannot be made out.
Okay.
This ulcer extends, involves the visual axis as well.
Okay, so whenever we describe such photo, we should describe first the infiltrate, okay, focal white opacity in the corneal stroma, and we will comment whether there is epithelial defect or not. And we will comment the same as you mentioned, conjunctiva and anterior chamber. So conjunctiva first, and if we can see the lid, we will comment. If there is eye discharge, we will comment. Epithelial, stromal, descent membrane, anterior chamber, endothelium. Okay. So what is the workup for keratitis? First, regarding the history, we should take careful history. Actually, bacterial keratitis or infectious keratitis can be managed clinically through history and clinical signs. Okay. Contact lens in details. We should ask everything. Okay. We should water exposure also is important. Trauma with vegetative any matter, like in agriculture people, farmers, fungal infection, sure, post surgery, any ocular medical or surgical history, LASIK or any ocular surface disease or systemic immunosuppression. These are the common bacteria with or the common infections associated with contact lens. Pseudomonas, it could be Acanthamoeba, it could be also fungi. Okay, immunosuppressed people, mycobacteria, it can be Candida, it can be herpes zoster, it can be also microsporidial. Ocular trauma with vegetative material, Fusarium, which is the filamentary fungus. Post-LASIK, most common mycobacteria. Okay. Examination. We will stain with fluorescein. We will do examination by diffuse elimination, direct sclerotic scatter, and specular reflection. We will see all the layers, same like I described before. I forget to mention the blood vessels. Okay, we should comment also on the blood vessels, extension from the limbal arcades. We should stain with fluorescein plus or minus Rosmingen. How we will comment? We'll comment on the size, depth, location of the corneal infiltrate and epithelial defect, and we'll comment on the anterior chamber. Okay. These are the methods of examination. I will not mention now, but only this picture for the sclerotic scatter. Okay, this is sclerotic scatter can detect any subtle corneal opacities. We should do uncoupling of slit lamp to be able to do this sclerotic scatter. Okay. I will skip what I can see. It's a general or known to everyone. And if anyone wants to stop me, just please tell. Okay. If we have real corneal ulcer, we should photograph it or draw it to be able to follow up the progress or the medication activity. First, I am going to start with bacterial keratitis. Bacterial keratitis, it could present differently according if it's gram positive or gram negative. As we can see in this picture, it's round, oval, grayish white, and definite. The borders can seen. Okay. If there is ulcer, there will be two edges, okay, one active and one undermined. And we can see here also there is hypopyon. In Pseudomonas, gram negative, it makes severe inflammation, severe suppuration, suppurative infection, same like this. And also this one also gram negative, okay, and makes mucopurulent greenish discharge. Pseudomonas is serious because there is a risk of perforation if not treated within 2 to 3 days. No cardiac keratitis. Actually, this is serious also, although it's superficial and slowly progressive, but it can cause endophthalmitis. It starts typical with shaped matter. Then it can cause later like tunnel. It is spread in the superficial plane and the risk of endophthalmitis. Fungal keratitis. Fungal keratitis, many presentations. Early presentation, it could mimic viral dendritic ulcer, and even it can present with picture similar to geographic keratitis, like if left over 2 or 3 days, maybe this patient came, he took medicine over the counter and came. And as we mentioned before, the risk is the vegetative trauma. And usually those people go to the pharmacy and take over the counter steroid. We can see it has fissury borders, only one satellite lesion. It has immune ring. If there is hypopyon, it will not be beveled. The bacterial one, it has a bevel, has a level, but here no, it makes like a tent. Also, sometimes it present with this picture, pigmented ulcer, and always the ulcer will be raised. It will not be flat, and this whitish will be tended to be yellow, not grayish. Okay. This is the fusarium. Okay. All this is inflammatory. In yeast, it can present with a picture like this pattern, sharp, demarcated, yellowish white, stromal suppuration, and small. This is the advanced stage. It has endothelial plate. Here it has limbal involvement. Here perforation. Microsporoidal keratitis. It has two forms. One form, this mild, it's like sticky lesions. Superficial, multifocal, granular punctate keratitis. It is similar to the viral punctate keratitis. And easily we can sweep it out by cotton tip. Or it can present with stromal infiltrate. Mimic also the viral disciform keratitis. Fissurium keratitis, it has the same like tentacle-like projections, okay, and it can present same like punctate epithelial, peripheral keratitis, ulcerative keratitis. It will make like gutter peripheral. So, can any other volunteer comment? I will select if anyone didn't. Dr. Wash, do you like to comment?
Yeah, there are two images. The upper one that's showing the paracentral whitish lesion. It's around maybe 2 to 3 millimeter, and there's associated with the ciliary congestion and hazy, also the hazy cornea. And lower one also there's a large whitish lesion and associated with hazy cornea and conjunctival congestion. So seems like corneal ulceration.
Okay, so you commented on size and shape. You commented on shape, right? Size and shape.
I didn't see any thinning or melting.
Okay, so what is your provisional diagnosis?
I will use the term that's a microbial keratitis.
Okay.
So it could be the viral, it could be the fungal or bacterial.
Okay. In comparison to this one, how can you differentiate between both?
Yeah, if we look at this right side images, there the margins in the lower picture, there's a very fluffy margins.
Yeah.
Okay, and in the left side, there are very sharp margins, particularly in the upper picture, left upper.
Okay, so you added now extra feature that this one like raised or fluffy. Okay, but the other one not.
Yeah.
So these lesions well defined, white and flat. These lesions ill defined, facially, and the color is yellowish and raised.
Yeah.
This
So
how can you differentiate between bacterial and fungal?
Yeah, exactly.
Thank you, Dr. Wash.
Thank you.
Next will be the acanthamoeba. Acanthamoeba, mostly she will be a woman or a girl with contact lens. She's coming with severe pain. Okay, so if you examine, you will find similar picture like this, but the patient's complaining with severe pain. There are some characteristic ring stromal infiltrate, okay, radial kerato neuritis, okay, punctate epithelial erosions. It can present also early with multiple areas of infiltrates and microabscess. It can present also early like pseudodendrites. Okay, and this is when it's progressive and there is hypopene. Can anyone discuss this?
This is the anterior segment photograph of the eye showing mild congestion with multiple radial whitish infiltrates and a dry looking picture.
Yeah.
Extending. And I mean, like, this is actually the radial perineuritis, a picture of acanthamoeba keratitis.
Okay. This patient is not acanthamoeba. This patient, it could be pseudodendritic.
Yeah, okay.
Okay. So this is a differential diagnosis of pseudodendritic. Okay. So please tell again and tell how can we differentiate and what are the other reasons or causes of pseudodendritis.
Herpes zoster ophthalmicus, ma'am. Healing epithelial defect.
Yeah. And the early fungal also.
Early fungal, yeah. Yes, ma'am.
So acanthamoeba and
yes,
herpes zoster simplex and the early fungal. Okay, next will be the viral. herpes simplex herpetic keratitis. It can present early without any corneal affection. It will cause a blepharoconjunctivitis. Then when it is recurrent, it will cause corneal affection. There are different forms. It could be epithelial, stromal, okay, and the stromal has many pictures, and endothelial. The epithelial one, the famous dendrites, okay, and it has some nice character by stain called double stain. When we stain with fluorescein and again we stain with rose bengal, it will be some highlighted with the pink. Why? Because it has some characters, linear branches with terminal bulbs. Usually it is located central or paracentral. So again, when we comment on any infiltrate or any ulcer, we should comment on the shape, the size, the location, okay, the color. It can present also with geographic ulcer when all these lines will coalesce together. It can present with stromal herpetic keratitis. Usually this is stromal herpetic keratitis not due to the virus itself, but due to the immune reaction. It can present with necrotizing or non-necrotizing. Necrotizing means the epithelium is not intact. Okay, non-necrotizing means it's stromal only. Okay, no intact epithelium. In case of endotheliitis, disciform, diffuse, or linear, and it will be associated with trabeculitis and high intraocular pressure. Herpes zoster, it can cause also, but it has some characteristic feature, the skin lesion, the typical skin lesion of the dermatome lesions of the face, and also severe pain. Usually also the patient has the history from before, and they're usually immunocompromised. What is the characters? Epithelial punctate keratitis, thick ruby dendrites with no terminal bulbs, or stromal keratitis. Post LASIK keratitis, in a patient with LASIK, he or she can attend with keratitis, infectious or non-infectious. Just a second, please. Sorry for the interruption. Infectious or non-infectious? The infectious usually occurs within 1 week. It has a similar picture, same like the infectious keratitis we mentioned before, or diffuse lamellar keratitis, which is sands of Sahara, same like this. It's a diffuse white sand between the flap and the stroma, the rest of the stroma. And typically it happens within the first 24 hours, within the first day. Okay. Marginal keratitis. Marginal keratitis, this patient called staph hypersensitivity. Okay, this is not really infectious, but from the hypersensitivity to staph. It could be single or multiple. It could be unilateral or bilateral, but mostly bilateral. Peripheral stromal infiltrates. Okay, there is clear space between the infiltrate and the limbus. Okay, variable stain. It can be accompanied by AC reaction minimal. Some injection it could happen. Some other form of blepharitis and other manifestations it could be there. So Again, please comment on this. Hello.
Yeah, this is a photo of anterior segment showing the branching pattern, multiple lesions at the center of cornea, and seems to be multiple mutton fat KPs and diffuse corneal haze, and conjunctiva was not appreciated well, either it is congested or not.
Actually, it is also pseudodendritic.
Yeah,
So it's
it's not
some
typical
linear,
dendrites.
yeah, some linear grayish white lesions, and with branching, and we should say no terminal bulbs. Okay.
So these pigmented, we can say these are the KPs like picture, or maybe
Because
inferior part.
okay, if we consider this patient as herpes zoster, he can present with the pseudodendritic, and he can present also with uveitis, because there may be tuberculitis also.
Yeah, these pictures also seems to be like anterior uveitis is associated with this
Yeah,
corneal ulceration.
this lesion. Yeah.
Yeah.
Thank you.
Yeah, please carry on.
I don't hear anything, ma'am.
Sorry. Okay, anyone wants to share his thoughts about this patient? He's old man, presented with decreased vision. There is the erythema of the right eye, and there is pain right scalp. He has pimples, forehead. Okay. The eye looks like the other photo, the bust photo. Okay. So what do you think?
It probably iritis with ocular hypertension could be the most likely ocular finding in this case, ma'am.
Yeah, perfect.
As this could be a case of HZO, herpes zoster ophthalmitis.
Yeah, perfect. Because this patient is herpes zoster, and yeah, he can present with trabeculitis and iritis and so. Okay, same point I mentioned to Dr. Wash, because the dendritic ulcer only terminal bulbs. Okay, but this patient not herpes simplex. So anyone want to have any thought?
Yes, ma'am. The right side picture shows the conjunctiva is white. The cornea shows stuck-on appearance of grayish white lesions on the cornea. More likely, the left side picture, the right side picture, more likely to be microsporadial keratitis. Then coming to the left side, they look like SPKs, which are more diffusely spread. Probably feuds.
How can we describe the lesion? On which level and
The left side one, ma'am.
Yeah.
They look more raised with mild subepithelial haze, raised SPKs with subepithelial haze is seen, and the clear intervening area is clear.
Okay. Thank you.
Yeah.
So this presentation is meant to confirm the comparison between the punctate epithelial keratitis in case of viral lesions and microsporoidal. What are the differences? In microsporoidal, it's stuck on same like you mentioned, more pinpointed. If you can see the other one like hazy, same also you mentioned. Okay. Smaller, lesser in number, epithelial level. The patient has had the history of conjunctivitis and maybe the history of a child playing in the water in the pond in the park. Fine. So we finished the infectious. Okay, apart from treatment, definitely. The non-infectious, very big.
Excuse me, ma'am.
Sorry.
The left side, yeah, the left side image, you said it's viral, but it looked more like a Tyson superficial punctate keratitis because there is no congestion and all. Yeah, it looked like it could be even that.
Yeah, it could be also. Yeah. How the theory mentioned this is viral because they know later on they confirm it by any other test.
Yes, ma'am.
Through the progress or whatever, but it's documented that this is viral.
Okay.
So
Yeah, even adenovirus can present like this picture also.
yeah, but the adenoviral always the eye is more angry more than this.
Yeah.
Yeah, when it affects the cornea, the conjunctiva is already completely injected and watery eye, photophobia. But yeah,
Tyson superficial punctate keratitis could be one differential diagnosis.
Yeah. So our next topic will be the non-infectious sterile ulcers, which is also a big topic. No time to discuss all these, but as a frame, it could be one infectious keratitis after it has been resolved. Okay, the meeting will end in 10 minutes, so maybe after 5 minutes I will restart. And it can be neurotrophic keratitis. Neurotrophic keratitis, it occurs in any patient has trigeminal problem. Trigeminal problem may be some diabetic patients has neuralgia or has nerves problem. It can be any reason affect the trigeminal nerve, herpes zoster. It can be exposure keratitis. Exposure keratitis related to the orbits, the leg of thumbs, the seven nerve, the facial nerve. It can be interstitial keratitis, like Cogan syndrome, syphilis. It can be immune mediated. It can be Morens, it can be Terence, it can be marginal keratitis, it can be allergic conjunctivitis, vernal keratoconjunctivitis, making shield ulcer. All these ulcers are sterile. It can be traumatic, it can be chemical injury related or thermal injury related, it can be following drops, it can be following surgery, bullous keratopathy or post-LASIK or like Sahara. It's sterile, okay? Post-keratoplasty, like rejection. It can be nutritional, like vitamin A deficiency keratitis. This group of disease related to connective tissue disease, rheumatoid arthritis, Wegener, which is GBA now, relapsing polychondritis, polyarthritis nodosa, systemic lupus. This patient will present with peripheral, unilateral, or bilateral corneal thinning, or infiltration, or ulcer. So thinning or infiltration or ulcer. The sclera may be involved. So here with peripheral ulcerative keratitis, the sclera may be involved. When this lesion will progress, it will progress circumferentially. And the patient might be presenting first before he is diagnosed by the rheumatology. We have other tearing, marginal degeneration. It occurs typically in men, bilateral, usually superior. Both eyes has progressive thinning of superior cornea. Cold eye, the eye is not injected. We can find fine banners along the central edge of the thinning. And also it will spread circumferentially. And the only problem of this kind of degeneration is astigmatism. Morin ulcer autoimmune. No one knows the reason. It could be related to systemic hepatitis. Okay. It is a diagnosis of exclusion. We cannot diagnose unless we exclude all other possible causes, connective tissue disease, and so on and so. It can present unilateral or bilateral. It's painful. It is spread circumferentially or centrally. So it can extend like arc or go through the center of the cornea. But important feature that it will not involve the sclera. It can cause perforation. Staphylococcal hypersensitivity, I mentioned before, peripheral white infiltrates, and there is a space between the limbus and the lesions. Exposure or neurotrophic keratopathy. It usually occurs in the inferior interpalpebral portion of the cornea due to severe dryness or exposure in case of fifth nerve or seventh nerve problem or proptosis or so and so and so. So I will disconnect now because it's 5 minutes and we will start again. So we start the management. Fine.